So this is, I'm sorry, now some of those slides that I'm going to show are going to be a little busy. I'm trying to make it as clear as possible. So this is really the flow of what the procedure is, and the green is what you do on week 1 only, okay? So on the first week, we would do everything, and on each subsequent week, 2 and 3, we would only do the white squares. So essentially, we do our cases under anesthesia. So the patient is prepped and put under. There's an exam under anesthesia, and then the first time around, and again, take this with a grain of salt because different facilities may decide to do it differently. We do the placement of the fiducial markers, of gold markers, to mark where the tumor is, and where to make the treatment reproducible on the first day. It could be done in the clinic by the surgeon beforehand, and that might save time from the procedure, maybe in 15, 20 minutes, half an hour, however long they take. We do it the first time around. Then, after this is done, we take the patient, and for us, the MRI suite, or the CT suite for that matter, are not integral to our operating room, to the brachytherapy suite. So we have to take the patient across the hallway to the MRI, and then this is where we place the applicator. We adjust everything, we do the scan, we transfer then the patient back to the operating room, and while the patient is being stabilized in the operating room, we do the planning, we do the pre-treatment verification, and proceed with the treatment. So the slides that are following are going to really concentrate on what we do, starting with the placement and all the way with to fiducial, to verifying the placement and going ahead with it. Placement of the fiducial markers, again, this is our setup at Sloan Kettering. We have a cone beam CT, a mobile cone beam CT, which is available in the operating room. So we can take fluoroscopy image and CT images of the patient. Cone beam CT is different than a regular CT in that you have a flat panel instead of high. So the images that you get with a cone beam CT have a lower soft tissue resolution, high resolution, but the depth of the pixels is kind of washed out, so it's very difficult to delineate different tissues, rectum from other muscles, from fat, and so on and so forth. So these cone beam CT images are typically used for verifying geometry using fiducials and bony. They're very commonly used for spine and geometry, but not for diagnostic. So this is what we use this imager in the OR for. And here you see the surgeon just placed, they have a preloaded needle with a gold marker at the tip, placing the markers in the patient. Why do we do this? Because we want to be able to have a consistent placement of the applicator in the patient. So we plan the patient with MR or CT, preferably MRI, and then we go ahead and we place the applicator in the patient again for treatment. How do you know it's in the right place if your cone beam CT has such a poor soft tissue resolution? Well, with the aid of fiducial markers, you're able to correlate the position of the applicator and the position of the fiducials in the patient so that they match. And you're not going to treat until you have a perfect match. And we'll go over that later. But this is why we go ahead and place the markers. When we go into the MRI, we need to do several things. Why do we do that simulation? One, we want to establish the optimal geometry for the applicator. And this is an iterative process. We place the applicator in, and we try different inflations until everything looks like it's optimally placed to make sure that longitudinally the tumor is in the right place so we can effectively treat it to make sure healthy tissue is pushed away. And this, we will go back and forth. Occasionally, we will also see that there's small bowel that can fall into the field. And one way you want to do that is maybe inflate the bladder and push the bowel away. So there's different tricks that can be used to achieve that geometry. We want to make sure that the positioning of the applicator is also reproducible, that it's stable, that we can go ahead and repeat it each time. And then, finally, we want to acquire a set of images that will simulate the actual treatment geometry. That's why it's called a simulation. So we want to make sure that we can see the tumor well, or the target volume. We can identify all the critical structures, that we know what we need to avoid. We can identify, distinguish the involved part of the rectum or anus from the uninvolved part of the rectum and anus, so we can spare tissue that is not involved with disease. We want to make sure that the applicator is clearly and fully visible, because we're going to digitize the applicator and the catheters in the applicator into the treatment planning system, so we know where the source goes, so we can calculate the dose from the source to the different targets and organs that we want to avoid, to make sure everything is properly done. And we also want to identify the fiducial markers to make sure that we can ensure a reproducible geometry at the time of treatment. So after all those steps are done in the MR or CT for that matter, the images are transferred to the treatment planning system. How do we ensure a reproducible position? And again, this is what we have at Sloan Kettering. If you go somewhere else, the equipment will be maybe slightly different. We use a leg ramp to place the patient's legs on, so that the tilt of the pelvis is reproducible each time. And then we fix the applicator. You see the applicator on the right side of the screen. We fix the applicator using this arm. This is an accessory that is provided by you guys with the applicator. This is not disposable as opposed to the applicator that is. And that hooks up to an articulating arm. This particular arm, again, if you're going to go into an MR environment, you want to make sure that you have an arm like similar to this one or something else that can hold the applicator in place to make sure that that position can be reproducible at the time of treatment. Most of these arms, if you are used to doing GYN cases, you use a Martin arm. Those Martin arms are made of stainless steel and they're not MR safe. So this is something that you want to make sure the facility has before you go ahead and do the case. Again, we make a note of everything that's done at the time of simulation. So the physician and the physicist are there. We make a note of the different filling of the inner baffle, the outer baffle. We make sure that, I'll go back to the previous slide, the stem has a marker that allows you to roughly estimate the insertion depth of the applicator. And so we mark that. And we also, if needed, we mark how many cc's of water we put in the bladder. So when we go afterwards, when it's time to treat the patient, we can reproduce the insertion, the different fillings to make sure that it's all perfectly reproducible. What kind of imaging parameters do we use? Look, many places recommend less than 3 millimeter slice thickness for imaging. I would like to see imaging at less than 2 millimeters. You want to be able to position the source within plus minus 1 millimeter. And so you're not going to be able to do this unless you have a 2 millimeter slice thickness. So yes, if you're doing it in MRI, this thinner your slices, the longer your scan is going to be. And At the same time, keep in mind that the patient is under anesthesia. So taking another 5 minutes to get an optimal image is well worth it. It's not like a standard diagnostic MRI where the patient is awake and you may have motion artifacts. When the patient is under anesthesia, everything is very stable and you'll see the quality of the image is excellent. Field of view, we don't need to take the whole pelvis. We can concentrate on the center of the patient, the center of the pelvis. So 25 cm is more than sufficient for that. And it will also allow you to take a higher resolution pixel size within the image, so you have a good resolution and you can actually plan things with confidence. You want to see the entire applicator. You want to go maybe 2 cm or more above and below. You may need to see critical structures if the patient had prior radiation and you want to account for this prior radiation. You want to go further above and make sure that everything is properly imaged and accounted for. For MRI, we recommend the T2 sequence. We recommend that the filling of the balloons and the bladder is done with water, not saline, because saline produces a very strong signal and may interfere with the imaging of the actual of other tissues. So water will create an artifact.
Joe, this is Rich. Real fast. What's the difference between T1 and T2 here, and why your recommendation for T2?
T2 is very good for soft tissue. T1 will actually not give you a very good tissue resolution. It is used for different purposes, and I think it's going into the MRI physics is going to be well. So I'm just going to leave it at that. But
that's fine.
See the tumor, you need the T2. You're not going to see it on T1.
Okay, and then as far as the saline versus plain water, that's because of the interference with MR as well, with the saline ion, with salt?
The salt in the saline will brighten up too much and create some artifacts.
Okay.
So we just recommend not to use it.
Gotcha.
Okay. And again, remember, each facilities will have different MR scanners, and so the sequence that we use on our MRI will not apply to another MRI. So they will have different sequences, and they will have to, trial and error. We found that the sequences that are used for GYN, so if you have a facility doing MRI for GYN cases, sequences can be fairly well translated for the AR applicator. Also optional, it really depends on your comfort level. We found that sometimes adding a small amount of CT contrast to the water in the outer balloon helps a little bit when you take the fluoroscopy and the cone beam CT in the OR, helps a little better visualize the balloon and makes the placement and adjustment a little faster. It's not necessary, it's optional, and it does not interfere with the MRI. And again, so these are the pictures that we showed.
Hey, Gil.
Yes.
When you say a little bit, what is a little bit?
I think we put in maybe 1 or 2 cc's of CT contrast.
Okay.
80, 90 cc of, you don't need a lot. It's just a little concentration of iodine just to give it a little different coloring, that's all.
Okay, fair enough. I bring it up because yesterday when we did the EAP, we did use contrast and the discussion about how much, and I remembered sort of the Mammocyte rule of anything over 10% will interfere with dose distribution.
Right.
So I just wanted to get some clarification on that from you, and again, wanted these guys to hear that. So carry on. Thank you.
Yeah, I agree. I agree with this completely. So, and again, so you want to make sure that whatever imaging modality you use, you see the full balloon and you see the catheters and you can identify the full length of the catheters. and you want to make sure that you see the superior, inferior, and the marker that's mounted on, we call it the north, which is anterior. We position this on the anterior side of the patient. So,
hey, Gil, this is Rich again. Of these 4 images, can you go what we're looking at? What's the imaging modality for each, so my team gets a better understanding of what they're looking at here?
yes. So the first one on the left is a CT image. The one on the right that my cursor is on is a cone beam CT image. The other 2 images are T1 and T2 MRIs. So the center left image is the T2, and this is the T1 image. So you can see the T1 is a little more washed out, and you have a little less contrast here between the epoxy and the, but essentially the applicator itself images extremely well in all imaging modalities, and you can get very clear reconstruction of the applicator, provided you follow, thin slices and make sure that everything is done.
And Gil, are we looking at the same phantom here? Because the one image doesn't have the epoxy indent.
It is the same image. It's just rotated. To be honest, I did the installation several times, so different occasions. I had to find time where the MRI was available. So you see here the applicator is inflated a lot more than it is here. You see the bulging up and down. On the CT, where I have pretty much free access, I did it at a different time, and here there was different inflation. But you can see that they're correlated.
Okay.
Okay. So why do we do MR? Why do I recommend MR and not CT? Because of visualization of the target and the structures. And so if you're not used to seeing MRI, you probably won't be able to tell, but the schmutz here, the white stuff here, that's the tumor, okay? On the CT, you cannot tell the difference between healthy tissue and tumor tissue. It all looks the same, okay? So if you're going to do CT, you will probably rely on the placement of the fiducial markers to tell you where the tumor is. So the placement of the fiducial markers, as well as maybe prior diagnostic MRI. But remember that diagnostic MRI was taken under different conditions without the applicator in place. So you have a lot of deformation. Also keep in mind that the rectum is a movable organ, right? So you may push it in or out. So it may be very difficult to very precisely and accurately, repeatedly locate the tumor on CT. So, and relying on fiducials alone is also problematic, as this picture shows. While this fiducial is right in the tumor, you may have other fiducials that missed, that went out. Okay? So fiducials may not be the best way to tell you where the tumor is. They will allow you to have a very reproducible treatment, but not necessarily a very accurate treatment. I'm going to move ahead. So now we have done the simulation and we sent our images to the treatment planning system. Very broadly, the 4 steps that are being taken are: 1, contouring, 2, identification of the applicator and catheters. We set the active dwell positions. We go and we optimize and evaluate the plan, and if it's okay, we can go ahead, do the plan QA, and proceed with the treatment phase. The contouring is done by the physician. Identification of the applicator and catheters is done by the physics, by the planner. So when we contour, we look at GTV, which stands for gross tumor volume, PTV, which is the planning target volume. Sometimes it's called CTV, clinical target volume. In brachytherapy, PTV and CTV are essentially the same. If you're doing external beam, they're not, so I'm not going to get into that difference. Sometimes your tumor is very localized, and you just want to keep your target to the GTV. Sometimes you don't have a GTV and you will only have a PTV. So I'm saying this is as needed. Again, this is not a strict protocol. And we counter the organs at risk. We counter the AR applicator, the outer surface of the AR applicator, which is the outer contour, and the three markers that I showed you before, the superior, inferior, and the north marker. We also go ahead and identify the fiducial markers that were placed in the patient. And we have a few contours that we use as tools to adjust the clinical targets, the clinical contours, as to improve the plan. And so one of those is a PTV margin or a GTV margin, depending on the need, and the other one is a normal tissue optimization structure. And I'll talk about all these in the next slide or two. So the GTV is essentially the gross tumor volume, and it excludes the AR applicator. So it's the volume of the tumor that is just outside the applicator. The PTV is a margin that we draw or expand upon the GTV volume. And again, it should exclude the contour of the applicator, because when you evaluate the dose to the tumor, you want to evaluate the dose to the PTV and GTV proper without the applicator itself. So the modern treatment planning system have Boolean operators that allow you to subtract the applicator from the GTV and the PTV, or do expansions in 3 dimensions, in 2 dimensions, and so on and so forth. This is something that your planners and the physicists are going to be very familiar with. Organs at risk, again, these are as clinically needed. The rectum is the healthy rectal tissue. It excludes the AR applicator, and it excludes the PTV margin. So maybe what I should do is I should jump down the screen first. So the PTV margin, once you have, think about your tumor, your rectal, you have a tumor that's embedded in the rectum, and you have healthy rectal tissue right surrounding it. If you're trying to get your dose optimized and maximized to the tumor, you may have a very high dose. You will have a very high dose right next to it in healthy rectal tissue or anal tissue. So what you want to do for planning purposes, to make sure that the treatment planning optimizer does not get too confused, you want to create a very thin space of maybe 2 millimeters between those two structures. So when we create the PTV, we create a margin around it of just 2 millimeters. And we take that margin and we subtract it from the healthy rectum, and thereby we create a small gap between the tumor volume and the healthy tissue volume. And I'll show an example after this slide. These are just a slide of definitions, and I'll show you an example of how this works immediately afterwards. So we take the rectum, we subtract the AR applicator and the PTV margin, and the same thing for the anus. We look at bladder, bowel, vagina, urethra, whatever structures may be of interest, may be of relevance, depending on the location of the tumor and sex of the patient and so forth. Everything else, I think, here is very straightforward. So in the interest of time, I'm just going to skip this because it's just definition. I'm going to move to the next slide. And here's, if you look at the bottom left slide where my cursor is, here is your GTV. The red is your GTV, and here is your PTV margin, or GTV margin in pink. And here is your rectum, and in brown below is your anus. So we want this really tiny gap just to be able to optimize, to maximize dose here and minimize dose to healthy tissue. And you can see in an axial, this is a sagittal slice. in an axial slice, you can see again your tumor, your normal tissue, and again your rectum. You see how this here on the rightmost panel, how the GTV margin expands and gets the healthy contour gap pushed away from the tumor volume. This is done in 3 dimensions, so you have the rectal contour going all the way around the applicator, and you want to minimize the dose right next to the tumor, and obviously just by virtue of being able to push the contralateral side away, you can minimize the dose to this side of the rectum or the anal muscle. Again, looking at how the applicator is contoured, we contour the whole balloon in the relevant area. We contour the superior, inferior markers, and we contour the north, the little marker that is mounted on the actual catheter pointing north. As we go into planning, this can get a little tricky, and again, this is something that is more of interest to your planners and the physicists at the various hospitals you go to. The way to do it is to first identify the north catheter by looking at the marker, identifying that marker, and then going catheter by catheter. So the north is catheter number 1. It will be channel number 1 on the afterloader, and then we go clockwise to 2, 3, 4, 5, 6, 7, and 8. So let's suppose we want to outline this catheter here. Okay, we want to identify that catheter. We will imagine a fictional line going through that catheter, through the center of the applicator, and through the opposing catheter on the other side of the applicator. If you can rotate this image so that this line now is vertical, right here. So we rotate this image clockwise or counterclockwise so that this applicator is facing up. Okay? When this applicator is facing up, exactly along the center of the applicator, you will see the whole catheter going through the applicator. It will be fairly straight. And you can digitize, you can identify the tip of the catheter, and you can identify the whole catheter all the way through. Okay? And this is crucial to be able to see the catheter clearly, know where the tip is, know where the end is. The other advantage of doing it this way is that then you see how long the tumor volume is that faces the catheter. So you can have a tumor volume for one catheter that's very long and for another catheter that's very short. So you want to create a conformal treatment by only activating dwell positions that are opposing the tumor volume. So you can activate the dwell positions that are right there next to the tumor. You can also see in this picture how the tumor is pressing against the applicator and how healthy tissue is being pushed away. Okay, so this would be the workflow. You identify the north, identify the channels you want to activate, rotate the image, identify the catheter, and activate the dwell time.
Gil, I think there was a question out there.
Yes. Yeah, no, and I didn't want to interrupt you. That was perfect. So this is Ken, and looking at these images with these 8 catheters, in this particular patient, you're only using one catheter. Is that correct?
No, I'm actually using one. You see my cursor. There's
yes.
1, 2, 3, 4, 5 catheters. 5 catheters are being used. I just showed one catheter here as an example.
I see. Okay. All right. Perfect. Thank you.
You don't have Ken, I don't know if it was clear. So what Gil's cursor was just on, oh wait, you can't see mine, but that top left image, that whole red area is the contoured tumor. And you can see there are the sort of the little purple indicators on each of those catheters that indicate that those are the catheters that are being used.
I see.
The beauty of this, if you look at the tissue that's opposing the catheter where that contour is drawn. If you look at the contralateral side, you can see that the balloon is kind of bulging away from that. So that tissue matter, that exophytic tumor matter, is actually pressed into the catheter, which is forcing the other side, the healthy tissue in the rectum, further away. So it's illustrating how the material, the balloon material, is actually working to protect healthy tissue.
I see. Okay. All right. Great. Thank you.
Yep.
Yeah, and this is seen right here. So you see the tumor volume here, and you see how it's pushed, the healthy tissue is pushed away on the other side. So then we go into optimization, okay? And again, if you're used to doing breast balloons, you have very strict guidelines on what's acceptable where. And here you have a really hodgepodge of some have had prior radiation, some did not. Some have diffuse tumors, some have a solid exophytic tumor. So, but as a guide, a rough guide, you want to maximize the dose to the tumor. So what you're looking here in this graph on the panel has the top right panel is called the DVH. And this is essentially a histogram. So if you have a structure and you throw in a lot of points in that structure, the question is, what is the probability that any point you pick will have a certain dose, okay? So we want to make sure that the probability that any point we pick inside the tumor will have the prescription dose to be close to 100%, which means we want perfect coverage of the tumor. So here, you see you have the 100% of the volume, or 100% of the point in the tumor are getting 100% of the dose, 5 gray. Prescription dose is delivered to 100% of the GTV. At the same time, we want to minimize, we want the dose to the rectum and anal muscle to be reduced as much as possible. And you see that a small segment of the healthy that's really close, remember that segment that was right next to the target volume, there will be a little tail here that will get a high dose, but it's largely spared. And this is what this DVH shows you. The other structure that we look at, remember I mentioned the normal tissue structure. This structure, let me go back to this slide here. So here's your target volume, and here is the normal tissue. It's very easy to just pump a lot of time in this catheter, in these 3 catheters here, and just blast everything around it. We don't necessarily want that. We want the dose to be conformal. We want a very high dose here, but we want the dose to conform to the tumor. We don't need to treat anything beyond the tumor. So by minimizing the dose to this green normal tissue structure, we're able to get the dose to be highly conformal, to treat the tumor and only the tumor. So this is shown here through this line that we're minimizing the dose to the normal tissue. And so when you look at your dose distribution, the minimum dose, the outer line of the blue, is prescription. You see it envelopes the target. It envelopes the target fairly conformally everywhere along. You need to treat the whole tumor, so you're making a little bit of a compromise here in the middle, and you give it a very, very high dose at the surface, an extremely high dose at the surface. At the same time, you're able to very, very nicely spare the rectum around, above, and the anal muscle below.
Gil, what was prescription dose for this?
5 gray.
Okay.
So the minimum dose here is 5 gray, and the maximum dose that I'm plotting here, so everything in the red is getting 200% of the dose or more. So this is a huge dose. So this is, see how much of the tumor. Let me go back to the DVH. So you're looking at 600 gray. This is going to be right about here. 600 gray is getting, 80% of the tumor is getting probably more than 600 gray. It's a huge dose. 90% of the tumors. We're really blasting this thing.
Overnight.
There's no way you can do this treatment with SBRT, to have this type of gradient and this type of high dose to the target with any type of SBR external beam. This is why Breaky works. Okay?
Great.
And again, this is another DVH for another patient, and or for the same patient. And again, you can look at the numbers. You can see that some of the normal tissue, there's a spill off of the target, but most of the normal tissue is very nicely spared. Again, we don't need to bring it all the way down because it's not a critical structure. We just want to have a conformal dose distribution. Critical structures are very, very nicely spared.
Gil, would you take a second and just kind of explain to them what that gradient that you're showing means, how the DVH works there? Can you do that in 2 minutes or less?
Yes, absolutely. So what you see here is that 500 gray, which is right here in the middle between the 4 and 6, 500 gray shows you that most of the tumor is covered by that dose. So everything in this area, okay, is covered by the prescription isodose. Essentially, you're looking at the percentage of the volume covered by what dose. What percentage of it correlates the volume of any structure and the dose that covers it. So if you're looking at, let's pick any point. Let's pick this point right here, roughly first. So this is 200% of the dose. This is 1,000. This is 10 gray. 1,000 centigrade. 1,000 centigrade is given to 40% of the target. Okay, so 40% of the target gets at least 1,000 gray or more. This is the high tail. This is the part of the target that gets blasted away. Okay, so think about it. Over 3 fractions, 40% of the target is going to get 3 times 10 gray. That's 30 gray in the course of 2 weeks. That's a huge dose. Okay. At the same time, you want to make sure that the critical structures are spared. So if you're looking at the volume that's getting prescription for the rectum and the anus, it's minuscule. It's less than 5%. It's less than probably 1% here. I can't just read it so finely. So this is the difference between the critical, the target and the critical structures. The tail,
so the takeaway that I'd like you guys to get from this is it goes back to the discussion that Gil was having with us earlier related to iridium as an isotope and its ability to drop off very shortly. So you can it almost speaks to the depth of penetration that specific isotope has and how quickly it falls off after, which allows you to very precisely target areas like Gil is talking about.
Right, and that was going to be my next point. So this tail here is due to that fall off because your source is so close to the target and you have a rapid fall off. This tail here is this high dose in the areas that are really close to the source. And this is where you get the ablative dose, okay? And this is the area that shows you what kind of cure you can get, so what kind of doses you can get. You can never get that tail with external beam. External beam, you'll have a sharp fall off of the target. Usually a uniform dose is given to the target in external beam. This tail, this long dose of high volume, half the tumor getting a huge dose, does not exist in external beams. Now, this is a step that is a legal requirement, checking the plan. So the plan has been done, it's approved, it's finished, now it has to be checked. And this is a pause, this is a timeout for physics to do their due diligence to make sure everything was done correctly, from SIM, that everything matches the doctor's prescription, that all the measurements, all the digitizations, all the doses, that all the numbers are all coming together and everything is right. And this may take 5 minutes, it may take a half an hour. however long it takes, let them do it. Do not interrupt, just, walk away, stand on the side. The physicians sometimes get impatient and they want things to get done quicker, but this is really, really important. It's super important that this is done correctly and quietly. So essentially what they're doing is they're making sure that you have the right patient site, prescription, everything is consistent as far as documentation, that you have the right geometry, and that you're giving the correct dose at the correct place. And this is crucial. Most of the mistakes in brachytherapy are because of incorrect geometry. This is really important that this is done right. So I'm just putting it out there because if you are in the clinic and you're seeing a case, you will see this happen, and you may see physicists back for it. Just give them a break and let them do their thing.
Hey, Gil, this is Ken Larmore.
Yeah.
Do you yet have, I guess, prognosis or results for these patients, or is it still too early to determine?
We have not had any toxicity for these patients. So this is a phase 1 study. We're looking at making sure that dose escalation in these patients is safe. We hope to be able to accrue enough patients to show efficacy as well, but we need a longer, we just started this year. I think, I don't remember, I think our first patient was when, February or March. So it's really too early to say anything about efficacy in these patients. But so far, we have not had any toxicity. All the patients have done.
Okay,
hey,
great,
Gil.
thanks.
When you say toxicity, what can you go through? What grades? Is that all grades, or?
We're talking about, there is some irritation, but we're talking about fistulas. We're talking about serious injury where you need serious intervention, and we have not seen that.
So would that be considered grade 2 and above, or grade 3 and above?
Definitely, yeah, grade 2 and I think we have not seen any grade 2 and above. I don't believe so.
Okay.
I haven't seen the latest clinical data, but I don't think we have seen any of that.
That's fantastic.
The treatment plan is awesome, and you're using Eclipse. Do you have an EBRT, SRT, a comparison by any chance?
Not for this.
Okay.
If you look up my name on Medline, we have done a comparison of SBRT and HDR for prostate, and we showed that you cannot achieve the doses you get with HDR brachytherapy. You cannot achieve that with SBRT with external beam.
Right. No, I agree.
All right. So now,
so I will be sending out the PDF that that Gil sent me, along with the protocol that they're using at Sloan, so you can review both of those, and again, kind of tie all of this together, and we can discuss that more next week.
I just want to go through the last portion, and then I'm done. So now that the plan is checked, we're going back to the OR into the pre-treatment verification. And this step is going to happen every week, because now the plan is finished. So when you come back next week, you don't have to replan. You just go back to the OR, place the patient on the leg ramp, fix the applicator with the articulating arm, with the Martin arm, whatever you have, get your inflations in place, and image the patient and say, do I have the same geometry as the one I planned for? So when we go, you can bring those images back into Eclipse or Pinnacle or whatever treatment planning system you use, and you can register your planning images, MR, for example, and your new cone beam CT. So you see the contours from the MRI. The contours are from the MRI of the superior, inferior, and the north applicator. You can see how the tumor presses on the applicator here, and how the rest of the tissue is moved away. and you see the marker that's in the tumor, right? So and you can see the shadow from the MRI. But you see the good alignment you obtain. You have the applicator in place, and the way you check to make sure that everything matches is, okay, I registered the applicator, now let's see how far my fiducials are from what I had in MRI. And you see you can achieve better than 2 millimeter agreement in position, which is fantastic.
Mm-hmm.
Now, again, this is with a caveat. You have to realize that the rectum is an active muscle. And if any of you are familiar with prostate seed implants, you know about seed migration. Well, guess what? You will have marker migration too. And sometimes we've had one case where the marker fell out, one of the markers fell out altogether. So instead of 3 markers, we ended up with 2 on the second and third treatments. So you may see that happening. So make sure you have enough markers out there so you can have a reliable treatment over time. You can do it with MRI and cone beam CT, and you can see the agreement. You align your marker, you see the contour of the marker, and the applicator aligns perfectly on cone beam CT, again, superior and inferior, and you can see the marker in the tissue, 1, 2, 3 markers perfectly aligning for this patient. See, this marker is actually maybe on its way out. On the next fraction here, we saw the marker out. So this is a marker that's probably migrating, but you can see how good everything looks otherwise. You can also do it with CT. And again, the same thing. You align the applicator, you align the markers, okay? And you can see that your cone beam CT and CT markers align well. Here, here. Once this is all done, you hook up the applicator to your afterloader. So north is channel 1, 2 is channel 2, etc. We never skip. We never say, oh, we only use 3 channels, so I'll use the first use channel on the applicator, which is channel X. I'll just hook it up to channel 1. No. Keep it 1-to-1, so you know channel 1 on the applicator is always channel 1 on the afterloader. It just prevents confusion. It makes sure that everything is consistent. What is the expectation when you go into a clinic? If you're going to be in and out in no time, well, not quite. Our experience is whether we do it with CT or MRI, first time around, with the planning and moving the patient, it takes us 4 to 5 hours, no matter how we slice it. MRI, just taking the patient and moving the patient out of the room and back in the room, whether it's CT or MRI, it adds another half an hour to an hour just right there, plus the time it takes in the scanner itself to do all the adjustments. The second and third insertions are a lot faster. We can get them in about an hour. Maybe if you're learning and it takes a little longer, maybe an hour and a half. But these are fairly quick, and that includes anesthesia and everything. So remember my flow chart from the beginning. That's end to end. You're looking at 4.5 hours, 4.5 hours, 1 hour in weeks 2 and 3. CT. We had one case where we had a CT because the patient had cardiac problems, and so MRI was not safe for that patient. We did not find that it saved us any time. What will save you time is if you have a facility that has a CT or an MRI built in to the brachytherapy suite, and then you can do it without moving the patient. That will probably save you 45 minutes to an hour. But otherwise, planning and doing everything, it just takes time, and to do it right, you have to put in the time. The process is going to vary greatly from hospital to hospital. We're Memorial Sloan Kettering, so we have several CTs, and we have an MRI in the department on the same floor, and we can schedule it and we can get the patients in. Other departments may not have it. So you may have a department where they will decide, you know, we want to do the simulation on week 0, and then come back a week later after all the plan is done and just do the application for the following 3 weeks. You know, we don't want to do this all at the same time. So instead of having 3 procedures, you will have 4 procedures that will be shorter. It all depends on how the facility wants to do this. I'm not saying anything is right or wrong. It's just whatever works for that hospital. You want to make sure that they have enough experience. Yes, hospitals differ, and everybody will have their own way of doing it, but you want to make sure that they do have enough experience and the right hardware to do it. So you want to make sure that you have the right source guide tubes available for them. You want to make sure that they have the right patient positioning device, that they have a stabilization arm, if they use one, that it is MR safe. Make sure that they have their sequences, if they're doing MR, that they have all their exam cards in place, that everything is set up ahead of time. You also want to make sure that they have enough experience. So if they're doing a lot of brachytherapy and they've done interstitial or multi-lumen breast balloons, they probably have enough experience to do this as well. If they have experience with CBCT and image verification, which most places will have because they also do IGRT and SBRT, then you should be in good shape. If they have limited HDR experience and they only do CT and MR-based intracavitary GYN, that's probably okay too. I would recommend practice and they come and maybe see another facility doing a case. We have people coming in and visiting. So, you know, people are welcome, physicians, physicists are welcome to visit and see a case. They just have to register with us. Kevin, you know the process, so we can easily facilitate that.
Yeah, I absolutely do, and I would help coordinate all of that. Just a quick note on the slide that you had, this slide that we're looking at right now. In a large part, these facilities are going to self-select. They're going to look at this. They're going to know what's involved, particularly when you start talking about anesthesia and you know, the potential for MRI, and that will also self-select. That's not to say we can't do it under CT, and there will be facilities that will be excited to do that. But anybody doing, as Gil mentioned, sort of intercavitary, you know, particularly a PBI will certainly be good targets for this because they have multi-catheter planning. And again, like I said, I think a lot of these are going to self-select based on their experience anyway.
I noticed all of the images were done at 3T. Have you tested this at 1.5? And what's the minimum field strength do you think you're going to be able to see the markers on this?
I think that I did not test it on 1.5. The 3T is the one we have in the department, and I did that. I suppose I could test it on a 1.5, but I suspect the visualization of the applicator is going to be just as good. The 3T is really for visualizing the tumors, and most diagnostic CTs out there are 1.5T, and I think that that you will have very good imaging on 1.5T as well. Again, remember, this is a really complex procedure. Things can break. You want to make sure you have spares. So if the facility has a case, make sure they have an extra applicator. I know a lot of people are money conscious and they say, all right, it's an 8-channel applicator, I'll buy 8 source guide tubes. Have extras. Things happen. You never know what's going to happen, and you don't want to be in the OR where your patient is under an applicator and all of a sudden you cannot deliver it. Last thing you want. So I recommend, this is our experience, we have spares of everything here. I recommend that any hospital that does anything has spares as well. Work closely with them, prepare ahead of time, sorry about the misspelling here, go through end-to-end tests, make sure that everything is properly coordinated with the radiology staff, with the therapist who image the patient, the therapist that treats the patient, if there's any nurses that are involved, anything that needs to be sterilized, make sure that everybody is on the same page. It really helps. Again, going back to we did an end-to-end test, and I thought, yeah, it's going to be a 3-hour case, and you end up waiting, and things take long, and anyway, you try to slice it. we ended up with at least 4 hours. So just keep that in mind. Make sure that everybody is aware and coordinate with everybody. And the last slide is a quote from Mark Twain. And again, you know, things are going to pop up, and you cannot prevent them, but being prepared and making sure that everything that you can possibly have in place is in place is really only going to help you. And I'm available to answer questions and help out. And if people at the facility have questions, they're welcome to come here and reach out. And if you want to come here and see a case, you're welcome to it. If you want to set up anything else before Astro, I'm away for the 10 days starting the middle of next week. But if you want to set up anything and go over things, I'm happy to do so. So please, you have my email, you have my phone number. Reach out and you know, make sure that you know you get it right. It makes all the difference.